ideally, this was the final chapter of the presentations that we were having over the course of a few weeks prior to this. So we'll, and the objective of this presentation is to look at the scope of the exam that you guys are doing in the next 1 week or so, the examination format and marks allocation, and then we're going to look at sample VIVAs that were done last year, and maybe talk about Pacemed, but I think most of you are aware of what Pacemed is, but we will have a discussion on that as well. So the 4th year examination is the junior clerkship examination, and the 60 is the senior clerkship. So the 4th year is we focus more on the OSLA history. OSLA we've talked about several times. So it's a long case, what you guys call a long case, but it's meant to be objective. So it looks at of all the systems and some multisystemic diseases such as hemato-oncology and endocrine. And the main focus really is how you take the history, how systematic you are, and so on and so forth. And then you might be told to do a general exam, rarely a systemic exam, and then you're told to what is your diagnosis from the history and so on. Generally, they don't ask you management plans unless you're looking for a distinction. So what is the examination format? The end of rotation is about 30%. So the end of rotation generally is a long case, does not have MCQs. Then end of year is 70%. So the MCQs of end of the year contribute about 20%. The long case and the VIVA contribute about 50%. So the VIVA contributes about 10 to 20% depending on the circumstances of the exam. So the VIVA is generally, you guys will be doing exams over 4 to 5 days. And each day, there'll be 2 questions of VIVA that will be given to everybody who is sitting for that day. And this will continue until the end of the 4 days or the 5 days. So at the end of the 5 days, there'll be about 10 VIVAs, which will be presented to you. And these VIVAs are very, someone asked, how is the internal medicine syllabus? The internal medicine syllabus is wide and deep. So the VIVAs can come from any discipline, they can come from any sections of internal medicine, and they're wide and deep. And then the 6th year team has the OSCEs at the end of the year. So this is the first VIVA. As you can see, this was the first day that this was asked in the last year. A 45-year-old female is admitted with 3 weeks history of progressive difficulty in breathing. On examination, she's wasted and has an enlarged right breast mass, it's supposed to be a mass, with retracted nipple, with pitting and dimpling of the skin around the areola. A chest radiograph that was done reveals a right-sided pleural effusion. So this is one question. So there are 2 questions every day. So this is the first question that day. So you are asked, what is the diagnosis of this patient? Diagnostic formulation for this patient, and then you're told to give justification. So ideally, a diagnostic formulation is an umbrella term of what the patient has, and then you give justification of why you've arrived at that diagnostic formulation. And the next question asks about possible risk factors. And then the next question asks the examination findings of pleural effusion. And finally, the 2 priority investigations and expected finding for this patient. So usually, Khalid, what we do with the 4th years is we make it as interactive as possible. We pick people to answer the questions. So I will give a few minutes, a few seconds for any volunteers to answer the question. If not, then we pick someone who we think might answer the question, so that it does not need to be a monologue or yeah. So let's make it interactive, and let's see if there are any volunteers to answer this question. So this is not a question that just came out of nowhere. You can see that it was a question from last year, and this is how it was presented. So this is what you're going to be examined on. So any volunteers for this question? All right, so we have someone in the chat. Harrison, inflammatory breast cancer, cancer breast with meds. So metastatic breast CA. So Hafsa Omar, you say metastatic breast CA. Odiambo said metastatic breast CA. We can, okay, so the most comprehensive that we have is Riak Abdi Ibrahim, who said metastatic breast CA with the right-sided pleural effusion. And maybe Riak can unmute and tell us. So what this is asking basically is basically the staging of the disease. What stage will this disease be? And what is your justification for that based on this vignette? So what do you guys think of this? Riak, you can go ahead.
Could we say we have an advanced breast cancer because of the nipple retraction and the skin dimpling?
So this will be which stage? So you're using the TNM classification, yes? So you're looking at the two things that are available here. Is the T available here? The T means the size of the mass, so to speak. And then N means the nodes that are involved, and then M means metastasis. So and indirectly we have the size of the mass, which can be what is the size of the mass based on this vignette. So when you have dimpling and pitting, what is that called? It's known as PD orange, yes? So PD orange is which T stage of breast CA? Okay, so let's go and consider this question. So when you're talking about breast CA, you're looking at two stages. You're looking at the clinical staging of the breast CA, and then later on, you're looking at the pathological staging of the breast CA. So how do you arrive at the clinical staging? You arrive through history, through examination, and then through non-invasive imaging or invasive tests. Sorry. So the non-invasive imaging that you can do is the mammogram, the ultrasound, the MRI, all right? And then you do your physical examination initially. And then in such cases, in such patients, then what you do is you stage using the clinical TNM classification. And in some patients, before you make an intervention such as surgery, you give them what is a neoadjuvant therapy. Neo means before, adjuvant is to help. So before surgery, you give the neoadjuvant therapy, then you can do surgery. So when you do the surgery, the tissues that you take, the mass that you take, and the nodes that you take, you do what is known as a pathological staging. So this is more accurate than the clinical staging. And then you can upgrade the stage, the clinical staging, or you can downgrade it based on the pathological staging. And then after that, you do other things on the tissues such as immunohistochemistry and histology and so on, which we'll look at in the subsequent slides. So what we have currently is a clinical staging, and we'll look at the clinical staging that we have in this patient. So when someone talks about breast cancer staging, so we use the TNM classification, we look at the T and we look at the M. In the vignette that was provided, the thing that the T that was provided is a breast CA that has caused dimpling of the skin and retraction of the areola, that is known as PD orange, and then PD orange is a T4 stage, all right? And then nodes were not given in the vignette, but what was given in the vignette was metastasis, which means pleural effusion is a malignant pleural effusion. So you have M1. So in that patient, you have T4 M1, which is stage 4 breast CA, right? And you are Your evidence for that is the T4, few orange features in the vignette, and the M1, which is the pleural effusion. So that is the diagnostic formulation. The broad diagnostic formulation is a patient with breast CA, T4, M1, nodes not known, who is likely having stage 4 breast CA. Anytime you have M1 or metastasis to any distant organs or tissues or pleural spaces or any spaces, then you have stage 4 breast CA or stage 4 lung CA or stage 4. If you have M1, it's always stage 4. So if you go back to the question, and the other things that were asked in the question was, well, if you go back to the question, what are the possible risk factors you would like to explore in the history taking? Is there anyone who would like to talk about the risk factors for breast CA?
Maybe let me try.
Go ahead.
Okay, so first of all, you do the, so you check for family history of breast cancer, previous history of breast cancer in the patient, history of contraception, history of, so nulliparity, if the lady has given birth, is the lady breastfeeding. You also do social history, so is she an alcohol or a smoker? Yeah, those.
Excellent, excellent. So those are generally the risk factors of breast CA. So breast cancer in young women and older women, but young women, it's more, it has different pathologies and so on. But what you have a genetic background. So you have this BRCA1 and BRCA2 gene, which have high penetrance. That means they move from one generation to another with high proportion. And then you have these other ones. You have history of nulliparity, BMI, smoking, alcohol, physical inactivity, and so on. Contraceptive use, like you mentioned. So these are the the wheel of breast cancer in terms of risk factors. Yeah. The other thing that was the question that also asked about the investigations. How will you investigate this patient? So you start with when you talk about investigations, you always start with the non-invasive investigations. So, but these are priority investigations. So you'll not start with a full hemogram, whatnot. Priority means targeted investigation. So the targeted investigation in this patient is a mammogram because of her age. Then if it's less than 30, 35, then you can use an ultrasound. And then an MRI if you want to now, characterize and stage the mass. And then if you want to stage the mass in terms of distant metastasis, you can do a CT abdomen, CT chest. And then if you want to do more characterization in terms of staging, then you can do a PET scan where you're looking at any uptake in any different tissues. Invasive. Now, this invasive conidal biopsy is a procedure. It's not. So what it does is you take a core of the mass. And what you do with that mass is the investigation, basically. So you do histology. You want to characterize the mass so that it's a infiltrative ductal carcinoma or whether it is lobular carcinoma, whether high grade, low grade, medium grade, and then immunohistochemistry to see whether it has which receptors. So look at this diagram that is below here. So this is for T2 now. Let's say this is T2. So you do histology, you do the grading. So you do the grading. So histology, then immunohistochemistry. So here you have the non-invasive things such as imaging. You get the size and you classify as T2 or T4. Then you do histology, it classifies as grading. Then you come immunohistochemistry, you classify with this, this hormone receptors such as Herceptin and estrogen and progestin receptors. And then you classify it based on that. It has you prognosticate the patient, basically. So what about the findings of pleural effusion? And I don't have to ask, I don't want to show. Let me ask this. So what in your examination findings? If the patient has pleural effusion, in this case, malignant pleural effusion, how are your exam findings in this patient? We covered last week the examination of the chest. Is there anyone who remembers who can take us through?
I can try.
Go ahead.
So on inspection, the chest is not moving respiration on the affected side. So if it's on the right side, the right side is not moving respiration. Then on palpation, there's reduced tactile parameters over the affected side. Then on percussion, there's also it's dull over the affected side because the pleural effusion masks the sound. On auscultation is also the same. There's reduced breath sounds over the affected side.
All right, excellent. There's only one correction that I'll make. Let me see if someone has said in the chat. So someone has already said in the chat, it's stony dullness. There's no increased tactile parameters, it's reduced tactile parameters. So it's stony dull. There's a difference between dull and stony dull, yeah? So when you say dull, there are only three differentials for dullness, and which are if the patient has a consolidation, lung collapse, or a pneumonectomy where the lung has been removed. So those are the differentials for dullness. And stony dull, when you have stony dull, is pleural effusion. So dull is different from stony dull. So these are the features of pleural effusion. So it depends on the size of the pleural effusion. So the one thing that I wanted to show you that tracheal deviation in pleural effusion occurs when the fluid is massive. You know, when you have about 1,000, greater than 1,000 and 1,500 is when you have contralateral tracheal shift or mediastinal shift. Like he's talked about, then you have the patient is breathless, chest expansion is reduced on the side that has the pleural effusion. Tactile parameters will be reduced on the side that has pleural effusion. Fluid is not a good conductor of sound, as opposed to solid. Solids are good conductors of sound. So that's why in consolidation, you have increased tactile parameters. Consolidation is a mnemonic process. And remember, histologically, mnemonic processes take up the consistency of the liver. That's why they talk about gray hepatization and red hepatization. So that when you percuss a patient with consolidation, it's as if you're percussing the liver, which is dull. And the same as patients who have lung collapse, there's no lung there, so it's empty, it's dull. And the same as when a patient has a pneumonectomy, the lung is removed, there's no air, it's dull. So those are the three ways that you can the three differentials for dullness. Tactile parameters will be reduced, and fluid is not a good conductor of sound. Breath sounds reduced, not a good conductor of sound. And forget about egophony and this bulging intercostal spaces. All right, I think we've covered that. Let's go to the next question. A 32-year-old female presents to the hospital with a 2-day history of right-sided weakness and slurred speech. On examination, her blood pressure is 178/98, heart rate is 99 beats per minute, random blood sugar is 50 millimoles per liter. She is noted to have a facial nerve palsy and a power grade of 2 of the right upper limb and on the lower limb. What is the most likely diagnosis? List 3 priority investigations for this patient. What is the likely predisposing risk factors for her current diagnosis? Can we get any volunteer? Probably a volunteer that is not the volunteers we've had before. A lady will be great if she volunteers. All right, so we have Salwa who said a left-sided strokes. Salwa, you want to unmute and tell us what the patient has? Okay. Any other one who wants to unmute and tell us what the patient has? Yes, it's nice to talk in the chat, but it's really interesting when someone speaks up and discusses this. And we've been doing this for the last few presentations, so I don't see the reason why you guys will be having an issue right now. All right. Hafsa Omar, you want to discuss this?
I can try.
Go ahead.
Okay, the patient here has a 2-day history of right-sided weakness, so we're thinking of an acute event, and there is also involvement of speech. She has slurred speech, and from the history, it involves cranial number 7, where she develops facial nerve palsy, and she also has features of hypertension and diabetes. So I'm thinking of a stroke, maybe ischemic stroke.
Okay, and let's go slowly, kidogo. What is the power grade?
2.
What power grade of 2, where and when? Upper limb and lower limb, yeah? So she has what, right-sided hemiplegia or right-sided hemiparesis?
Right-sided hemiparesis.
So she has a right-sided hemiparesis with involvement of the facial nerve. We are not told whether the facial nerve is left or right, okay? So we assume it's this. We assume it is, okay, let's put the facial nerve aside, it will complicate things. So she has a right-sided hemiparesis, all right? Where is the lesion likely to be?
Left.
So the lesion is likely to be in the left side of the brain, so it can be in the left cortex or the left brainstem or the left, okay, left-sided cortex, left internal capsule, left brainstem, yes? So you are told, so what can localize it? What is presented here that can localize it? To either the cortex or the internal capsule or the brainstem. Victor has raised his hand. Victor, you want to add on this?
So
You can unmute Victor too.
Will
Yes.
the slurred speech help us localize the lesion?
So the slurred speech will help us localize the lesion. So there's a difference between slurred speech and aphasia. So when someone is talking about slurred speech, they're talking about dysarthria. So this dysarthria, we don't know whether it's because of the facial nerve or it's because of aphasia. So they have not really talked about aphasia in this patient. They've talked about slurred speech, which is dysarthria. So there's a lot in terms of localization that can. So if the patient had aphasia, then that means that the lesion is, Victor, the lesion will be where if the patient had aphasia?
I think the cortex.
The cortex. And if the patient had dysarthria, where will the lesion be with the facial nerve pulse?
It will be a bulbar lesion.
Okay. Phonation of speech. So the most likely diagnosis, like Hafsa has talked about, is a right-sided hemiparesis, likely due to a stroke. We don't know whether it's a hemorrhagic stroke or it's a ischemic stroke. So you say likely due to a stroke in the left side of the brain. You don't know whether it's the cortex or the brainstem because it's not clear whether there's aphasia or just slurring of the speech. But from where I can see, if it's slurring of speech, it's a dysarthric patient. So I'm thinking it's the facial nerve palsy that is causing problems with phonation rather than aphasia in this patient. So if that were the case, where will the facial nerve palsy be in this patient? This is outside the question that has been asked. But Victor, this facial nerve palsy, if it's a brainstem or if it's a cortical lesion, where will the facial nerve palsy be? Will it be on the same side or will it be on the other opposite side? And if it's a brainstem lesion, where will the facial nerve palsy
The pons.
All right. So if it's a cortical lesion, let's say it's a cortical stroke, the facial nerve palsy will be ipsilateral or contralateral.
Will it be contralateral?
Meaning that it will be on the right side, same as the weakness, yes?
Yes.
So, and what about if the facial nerve is, is in the pons? What will be, if the lesion is in the pons of the brainstem, the lesion will be lower motor or upper motor? So the nucleus of the facial nerve is in the pons. So if you have a stroke there, the lesion will be lower motor because the nucleus is the equivalent of the motor neuron in the spinal cord. So you'll have a lower motor neuron lesion, and the difference between an upper motor and a lower motor neuron lesion is the sparing of the creases. So upper spares upper, and lower spares nothing. So generally, we digressed a bit, but that is how I will have approached this case. So let's see what. So the diagnosis is a right-sided hemiparesis with facial nerve palsy, likely due to a stroke in the left cortex, in the left side of the brain. We don't know the localization where it will be likely. So, and the three things that we need to differentiate: aphasia. So there's a problem with language itself. That means the production of language and the understanding of language. That is aphasia. Dysarthria is a problem, is a motor issue, is a problem of speech production. So language is okay, but you have a problem with speech production. So you have problems with, neural problems such as facial nerve palsy or hypoglossal nerve palsy or a glossopharyngeal nerve palsy that affects the phonation of speech, be it the consonants or the vowels, mostly the consonants. And then aphasia is a problem with language itself, the understanding of language. So stroke, how will you classify it? So the most common stroke is ischemic stroke at 88%, and then you have hemorrhagic stroke at 12%. Of the ischemic stroke, you have a lacuna and a non-lacuna stroke. Lacuna means small vessel, and then non-lacuna is either large artery because of atherosclerosis or cardioembolic because of cardioembolic phenomena. You have rheumatic heart disease, or you have congenital heart disease that is throwing clots to the brain. And then you have this cryptogenic, means that we don't even know what is causing that. So this is how stroke is classified. Remember that lady, apart from hypertension and diabetes, she's also young. She's 32. So that is stroke in the young. So apart from diabetes and hypertension, there are other risk factors in stroke in the young. So let's look at. And so how will you investigate this patient? What sort of investigations will you do that are level 1 evidence, which means that world over, this is what is agreed upon that we do for these patients? Any volunteers for that? Okay, so as people are making up their mind, let's go and look at this. Imaging, you start with imaging in patients with stroke. You don't want to waste time. Within 10 minutes, you want to do your CT head, non-contrast. It will pick out if there's a hemorrhagic stroke. And sometimes it can pick, if it's late, it can pick a patient with ischemic stroke. If it's early, it will not pick. So if it's early, it has not picked, then you can do what is known as MRI, DWI, where it will show early phases of stroke in such patients. The other thing that you're supposed to do is an ECG. You want to know whether there is atrial fibrillation that can cause the stroke. And this is more in patients who, like young patients with risk factors for stroke, such as rheumatic heart diseases, but it's a standard for everyone. And then you do a carotid Doppler. You want to see whether there is carotid artery stenosis or carotid artery atherosclerosis that is causing a stroke and in such patients. The labs basics, you do your CBC, you do a coagulation profile in patients with hemorrhagic stroke, and both of them basically. And then you do a lipid profile. You can do a fasting or a non-fasting, and then HbA1c in such patients. What are the risk factors for stroke in this case? Like risk factors are hypertension and diabetes. The other is, so she has modifiable risk factors, meaning that with drugs, this can be controlled. The non-modifiable risk factors are old age, male gender, and then non-white means Black patients and Hispanic. Then family history, if you had previous history of stroke, then likely you may have a genetic predisposition, and then prior stroke or TI. TI is the most important risk factor for stroke. Then hypertension is the most prevalent. So that's an MCQ question. Previous TI is the most important risk factor for stroke, and hypertension is the most prevalent, okay? All right, so let's move on to the next question. A 57-year-old unidentified male is found on the streets in a drunken state and rushed to hospital. On examination, he has deep jaundice, uniformly distended abdomen with no pedal edema, and flapping tremors. What is the most likely diagnosis? List 5 physical examination features of chronic disease that are likely to be found in such a patient. Give 3 underlying etiological causes of the disease mentioned above. Are there any volunteers for this case? Are there any guys who are currently rotating in gastro ward who would like to volunteer and to answer this question? So I can see a few people that I know. Let me see if they're able to answer. Let me see. All right. Let me see. Christine, you want to try this? Christine Muema?
Yeah, I can try.
Go ahead.
Maybe I would say the most likely diagnosis is alcoholic liver disease that's presenting with complications of hepatic encephalopathy because of the flapping tremors. That's what I'm thinking.
All right. So before you go to hepatic, before you go to alcoholic liver disease, what is the broad umbrella diagnosis for this patient?
Chronic liver disease.
Yes, but there's something before the chronic liver disease. Is it compensated vis-a-vis decompensated?
Oh, decompensated.
So decompensated chronic liver disease likely due to alcoholic liver disease, yeah?
Okay, yeah.
So it's a really straightforward question. And what is in the physical examination, what are you going to find in this patient? Apart from jaundice and the flapping tremor.
Maybe pulmonary edema, deputant contracture, the spider navy, gynecomastia.
Go ahead, continue. So you've started with the hand, you've gone to the chest, now you're coming to the abdomen, yeah?
Yes.
So what will be in the abdomen?
Perhaps caput medusa. The ascites has been mentioned in the question. Yeah.
What about below the abdomen? So you'll have testicular atrophy.
Okay, yeah.
And then below in the legs, you'll have what? You'll have pedal edema, yeah? So let's say that this patient was just, alcohol was just there, but what other etiological causes will chronic liver disease be due to? So what other conditions will cause chronic liver disease? Joy Ego, are you in the call? I'm asking a lot of ladies. I need to ask the men now, the guys now. But Joy, what do you think of etiological causes of chronic liver disease?
Yes, I'm in the call. We have hepatitis, so chronic hepatitis.
And so which one, viral, non-viral?
Viral.
So which one's viral?
Hepatitis B.
And
C.
yes, okay. What else? Alcohol, okay. We talked about alcohol. Anything else?
Not sure about autoimmune liver disease.
Yes, autoimmune. And in diabetic patients? There is non-alcoholic fatty liver disease or metabolic associated steatohepatitis and liver dysfunction, yeah? So let's look at this. Thank you, Christine, and thank you, Ego, for answering the question. So you have these patients, they present with, so cirrhosis is really an imaging and a pathophysiological diagnosis. So these patients, hepatitis B, chronic hepatitis C, alcohol, and non-alcoholic steatohepatitis, others such as autoimmune or infiltrative such as hemochromatosis. So this will present with cirrhosis. And then because of precipitating factors, they can go into decompensation. And decompensation is defined by ascites, upper GI bleeding, and hepatic encephalopathy, not jaundice, just those three. And then they can either, if they have other organ dysfunctions, then they can go into what is known as acute on chronic liver failure, such as when they have acute kidney injury, or they have other conditions, respiratory failure, and so on. So what are the precipitating factors? These are the precipitating factors. So infections, if someone has chronic liver disease and then goes for another binge drinking, then it's a precipitating factor. Then you have this variceal hemorrhage, makes things worse. You go into ascites or a hepatic encephalopathy. Then you're given drugs that can impact the liver, so you get a drug-induced liver injury, and then you get other viruses on top of the previous ones that you had. And then these are the signs like Christine has talked about, all right? So deep jaundice, you have the gynecomastia, spider nevy, you have leukonychia, clubbing, palmar erythema. So palmar erythema is a misnomer. It's not in the palm really, it's in the pads, the thin and hypothena, and the palm is really pale. The rest is, so this is a sign of hyperdynamic state. And then you have edema of the legs, and then you have ascites. And then you have all these things that Christine talked about. All right, so let's go to our next question. So now we'll need to hear from the men. A 42-year-old male long-term resident of South Sudan presents with fever, weight loss, malaise, and left-sided abdominal swelling for 3 years duration. On examination, he has a palpable mass in the left hypochondrium that extends to 12 centimeters below the costal margin. Lists 4 signs that are specific to this mass, give 4 differential diagnoses, and name 2 priority investigations for this patient. And any volunteers, I'm talking to them, the XY chromosome now.
Trial.
Go ahead.
So you expect to find a splenic notch
Mm-hmm.
It has a lower border but not an upper border.
Mm-hmm.
Then it extends towards the right lower quadrant.
Mm-hmm.
Yeah, towards the right lower quadrant. I don't know the find it.
All right. What about the diagnosis? What do you think of?
It's splenomegaly, so it's massive splenomegaly.
Moderate to massive. But what do you think of the 4 differential diagnoses in this patient? So basically what they're trying to ask in this question is what causes massive splenomegaly? Although the definition is about 18 to 20 centimeters, but yes, but that's what they're looking for. What do you think?
Oh, so there are the causes of moderate to massive splenomegaly can be leishmaniasis, tropical malaria, Gaucher cerebrosides.
Mm-hmm.
Leukemias, lymphomas. Yeah.
Okay, so no leukemia, but which lymphoma? All right. So let's go to it. Thanks, Bill. So this is the liver can extend all the way to that side, all the way to the hypogastrium. We saw a patient, I think, this week with a left liver lobe mass, which was going all the way to the hypogastric region. So when you're examining for hepatomegaly, kindly remember that you're not just examining the right side of the right lobe of the liver, you're also examining the left lobe of the liver. And then the spleen, and like Bill has talked about, it goes all the way to the right iliac fossa, and you cannot go above it, but it has a definite lower border. It's not bimanually palpable. It has a splenic notch on the medial aspect, and then it moves with respiration. So it moves with respiration just like the liver does. So, and those are the features of splenomegaly. And so no palpable upper border, not bimanually palpable, notch on the medial border, moves inferiormedially on inspiration. Dull to percussion, friction rub here or not there. Massive splenomegaly, like Bill has talked about, CML, don't forget that. So CML is one of the most common causes of massive splenomegaly in adults. And then you have myelofibrosis, and then you have Gauchers in predominantly Caucasian populations. And then you have these lymphomas, specifically splenic B-cell lymphomas. And then you have Kala-Azar in our setup and in this patient who's coming from Sudan. And then malaria, this malaria it's not really malaria that is causing the splenomegaly, but hyperactive, the inflammation that has occurred due to multiple malaria episodes. So if you examine this patient and you take a malaria slide, you will not find malaria, but you'll find malaria antibodies. All right, so it's different from the malaria that you have. So this is hyperactive malaria syndrome. So what you have is the autoimmune, the immune reaction to malaria that has occurred and during several episodes of infection. Then you have beta thalassemia, and then AIDS with MAC, Mycobacterium avium complex. So how do you investigate this patient? What are the likely investigations? And I And so Ian Sama, Ian, what do you think of how will you investigate this patient?
Hi, Doc. Yeah.
Well, what is how will you investigate this patient?
Okay, so you can for labs you can do you total blood count. So here you want to check for so if it's malaria or Kalaza can have an marked eosinophilia. In malaria, we can also have a decrease in your red blood cells, red blood cell count. Yeah, and then you can do, so apart from the full blood count, you can also go ahead and do splenic aspirate. You can do bone marrow aspirate in the cases of the Kalaza.
Good. Go continue. What will you get in the bone marrow aspirate?
Yeah.
You get what is known as the
Hello, Doc, you're muted. We can't see. We can't hear.
sorry, and am I audible now? There was
Yes,
a network challenge.
yes, now you're audible, Doc. You can continue.
All right.
Reshare
So
screen.
all right. So the investigations are divided into parasitological and molecular, and then you have the serological investigation. So parasitology. So the although it's invasive, bone marrow has several advantages over other tests. It can diagnose leishmaniasis, it can diagnose CML, it can diagnose other conditions that may lead to splenomegaly. So if you're told to, if anywhere you meet someone and he's trying to examine you and tells you at least one priority investigation for a patient is splenomegaly, just say a BMA. But now that we're thinking that this patient has visceral leishmaniasis, you also do lymph node aspiration. But the one that we use commonly is we do the strip tests, the rapid test. It's called RK39. So we do that. And the other thing that we can do is ELISA. And in other labs, they can do a PCR test for leishmaniasis. So if you, the important things here is to the RK39, ELISA, and the bone marrow aspirate, where you want to diagnose leishmaniasis in this patient. All right. So this is our last case. A 28-year-old patient presents with 2 weeks history of ascending weakness. The patient reports previous history of progressive back pain, which was radiating down the leg, which is expressed as electric light or shooting pain. The pain was also not, the patient was also noted, it's not the pain, the patient was also noted to have facial diplegia. On exam, the reflexes are absent. What is your diagnostic formulation for this patient? And what is your priority investigation? I put treatment there, but we can leave the treatment for now. And any volunteers for this case? So I can see people have written GBS, GBS, GBS. Okay. All right. Any volunteers who will take us through the why this is GBS? And okay. What about
Good.
let me see. Yeah, go ahead.
Yeah, okay. So our patient here is presenting with an acute ascending, let's say, weakness, because we haven't been given the powers. So ascending weakness, so which sits in with GBS because of one, the loss of the areflexia, which is in keeping with motor neuron lesion, and then there is no urinary or bowel incontinence, and there is no loss of sensation, so there's no sensory loss or sensory level for a patient.
What about the what is diplegia?
I'm not sure about definition, but I'm not sure about that. Yeah.
Okay, someone is saying Marang. Okay, Victor raised his hand. Victor, what do you think of the facial? What is facial diplegia? Victor, you can unmute. Okay, someone has answered in the chat saying the bilateral facial nerve palsy. Yes, bilateral facial nerve palsy is facial diplegia, and it's one of the features of facial nerve GBS. And all right, so let's consider this. What is the priority investigation in this patient? Simple investigation. What should tell you, Maranga Kelvis? What do you think? What is the priority investigation in this patient?
We can do CSF analysis. Yeah, so you get albuminocytologic dissociation. So you get
what will tell you that this is GBS?
Albuminocytologic dissociation. Now you get increased protein, and we can also do nerve conduction studies.
Excellent, excellent. So what does dissociation mean? So it means that usually when you have an inflammatory response, you get both cells and albumin or proteins that are high. They go together. But right now you have CSF that has no cells or has low cells and an increased protein. So that is albumino cytologic dissociation. They are dissociated as opposed to usually when they're supposed to rise together. Okay. So let's see GBS. What do you need? Yes. So the features required weakness of more than one limb, a reflexive or hyperreflexive. In this patient, you had a reflexive or hyperreflexive ascending paralysis. That is the diagnostic formulation for that. And then features that strongly support GBS, relative symmetry of symptoms, progression that is subjective over days, mild sensory symptoms or signs. So that's why I put the acroparesthesia. So they have this, which is known as acroparesthesia. Acro. The hands and the leg, they get these paresthesias, and there's a variant of GBS that has that. Cranial nerve involvement, especially bilateral facial, autonomic dysfunction, which means bradycardias, tachycardias, and that is a common cause of ICU admission and so on. And then pain, elevated CSF protein, and then nerve conduction studies that are characteristic for GBS. So you have these variants of GBS. So the one that this patient had is, he had both, he had facial diplegia in this category, and he had the ascending paralysis. So it was going up, so you can take this. So you can have a motor sensory where the motor is more predominant. You can have pure motor. You can have paraparetic, but it's rare. Then you can have this pharyngeocervical brachial. Then you can have this bilateral facial or facial diplegia. Then you can just have pure sensory. You can have pure sensory that occurs earlier before motor symptoms. Then you can have this Miller-Fisher syndrome, and then this Bickersbach encephalitis. So these are the patterns, variants of GBS. We have one more question that Khalid is going to share in the chat, that I put a poll in the Twitter page of Pacemedicine. One question that came last year that was a bit tricky, so I put it in Pacemedicine Twitter page. You guys can go and vote, and we see. Khalid, kindly share that question in the group so that guys can go and look at that question. And kindly, when you go there and you vote, also follow us on Twitter. And the idea is we want to post more cases and so on. So that is the end of our session tonight. We took a bit longer, maybe 5 minutes longer, since we started late. And any questions, clarifications, and concerns that you guys want to ask regarding VIVAs or in general the exam that is upcoming on, I think, Wednesday or Thursday, and then later on in June. Khalid, back to you.
Yes, thank you, Doc, for the engaging session. We really appreciate the tutoring that we've had tonight in preparation for exams. So on behalf of MSAUN KNH, we really appreciate everyone who's attended the meeting today. Thank you very much, and good luck in your exams, inshallah.
Are there any questions? There are no questions so far.
No, there's no questions in the chat.
All right.
Thank you.
From my end, I also say the same to all of you. Congratulations. These are the same exams that you guys have been doing. It's just a bit different. It's your first clinical. You'll do more clinicals from now on. So confidence and the rest, you guys have already, that is your knowledge. So all the best. And to MSAUN team, thanks for inviting me. Khalid, thanks for the moderation. Hope to do more of this. Someone is saying